Welcome to the LACNETS meeting for April 2015. I'm Giovanna Imbesi, and we have a few announcements before we have our guest speaker today. One is that we have a very, very important guest today, Chip Rubin, and many of you know Evelyn Long, who's a long-time survivor of carcinoid. Her son, Chip Rubin, is a medical writer. And about 8 years ago, he published something, which was this little book, which is a guide to diagnosis and treatment for carcinoid tumors. And this really, at its time, was one of the only resources available 8 years ago. And it's a very comprehensive guide, and it's since been updated, and it's available online. So if we want to stand up, Chip, and just say thank you for being part of our community.
It's old.
It's old, but it's been updated. So Dr. Warner in New York, Dr. Richard Warner, has this available, the updated version on his website. And I can send out the link for that as well. And there are also some flyers that Evelyn was kind enough to make copies of about Dr. Warner and from his website. So thank you, Evelyn. And we honor you for being so involved in the community and being such an inspiration.
I'm honored to be here, and every day is a blessing. It's been almost 12 years, so I'm thrilled to be here.
So a couple of other announcements. I was in Barcelona last month for the European Neuroendocrine Tumor Society meeting, which is the original group of physicians meeting. We have LACNETS in the United States and Canada, which is the North American version. To give you an idea, the European attendance was about 2,000, and in the US it's about 200. So it was quite exciting to be there. And I had occasion to have a dinner with Dr. Oberg from Sweden, who is working on some very exciting research with oncolytic viruses. They're starting some trials coming up this year, and you hear more and more the C word of cure on the horizon. And somebody else had just mentioned the PBS special with Ken Burns, based on the book Emperor of All Maladies. And so again, there's more talk about immunotherapy and advances in this way. Stanford is going to be opening up their trials, working with Caring for Carcinoid Foundation in this area, and they haven't announced criteria yet, but that's coming. So immunotherapy is definitely a buzzword, and there was also a 60 Minutes piece. So lots happening in that direction. And I know we have some newly diagnosed people here today, and please feel free to ask questions, and I know it's a lot of new vocabulary, and there's such a range of experience in this room between patients who have, decades of survival and some who just found out what the word carcinoid means. So today, as you know, there's so many people on the neuroendocrine team, and we always talk about the multidisciplinary team of having many doctors, so you may see the oncologist, but then you'll see the endocrinologist and a surgeon and a radiologist and an interventional radiologist, and of course all the insurance people. But one of the really critical members of that team is the pathologist, because the pathologist's work then and determinations then influence all of the other decisions that the team members are making based on that information of what they're seeing under the microscope. So they may not be the people that you see at the forefront, but behind the scenes, that's where a lot of the work is being done. So we're very fortunate to have an exceptional pathologist who's done a lot of research and published on neuroendocrine tumors with us today. Please welcome Dr. Deepti Dhall.
Hi, everybody. My name is Deepti Dhall. I came to Cedars-Sinai around 9 years back, and I did my training from Memorial Sloan Kettering Cancer Center. I was trained by Dr. David Klimstra. If you really put neuroendocrine tumors in Google, and you will see his name everywhere. In fact, he's the main pathologist in LACNETS, and all the guidelines, recent guidelines, are all written by him. So my interest of neuroendocrine tumors came from him. When I came here, I met Dr. Wallen. He was treating all the patients with neuroendocrine tumors, and I worked with him closely until he left. We wrote some papers together. And yes, my interest is in neuroendocrine tumors. I've been seeing these tumors for almost 10, 15 years now. And every time we get a neuroendocrine tumor in our department, I look at the slides and people come and take, their opinions. So if you have any pathology-related question, feel free to ask. I've not made any presentation. This presentation is just a lecture which I give it to residents, and I gave it in grand round. So I thought if you ask a particular question, it's nice to see pictures. Pathology is all about pictures. We look a lot of pink and blue and then make those diagnoses. So it's all based on the pictures. And I can take you to into pathology world if you have any questions about it.
Great, so we had some questions that were submitted on
Sure.
the website, and I thought this might start out as a basis for our talk. So one was, how are neuroendocrine tumors classified and graded?
Okay, that's the big thing. It all began in 2010. Before that, the classification was really vague. There was no criteria for grading, and it was very difficult. But there's a WHO classification of neuroendocrine tumors, and let me show you a slide which would be easy to explain to you. So yes, the classification has been evolving, and the most recent, you want to look at this one. So first, we have to make a diagnosis of neuroendocrine tumor. Before going into neuroendocrine tumors, the general category is neuroendocrine neoplasms. We look at this slide, and then we determine if it's a neuroendocrine tumor or neuroendocrine carcinomas. That's really important, because even though both kinds of tumors are neuroendocrine, but a neuroendocrine tumor is very different from neuroendocrine carcinomas. Once we make a diagnosis of neuroendocrine tumor, in pathology we grade the tumors and we stage the tumors. Now the staging of the tumor is based on the tumor size, and it's a very site dependent criteria. So tumor size, how deep the tumor is going in the organ which is involved, and whether there's any metastasis. The grading of the neuroendocrine tumors is based on the mitotic activity and Ki-67 proliferative index. These are the things you see how rapid the tumor is proliferating, and that decides the prognosis of the case. So grading is done based on mitotic count, and we see mitosis on the slide. And Ki-67 proliferative index is an immunostain. It's kind of a stain. We stain the slide with an antibody, and that will pick the cells which are proliferating. It's more sensitive, it's more objective than mitotic figures. So this is how we grade these tumors, and there are 3 different important grades in a neuroendocrine tumor. One is G1, which is low grade. Most neuroendocrine tumors are actually low grade, and if you look at the 2 columns, the mitotic count will be less than 2, and Ki-67 index would be less than 3%. And in the next one is G2, which is intermediate grade. You see a higher mitotic count and a higher Ki-67 index. And G3 tumors are pretty rare. So let me show you some pictures how it looks like to us. So for example, it's hard to move. So these are how the tumors look like. We in pathology we get the specimen which is resected. For instance, in this picture you're looking at different kinds of pancreatic neuroendocrine tumors. So you can look at these masses, and then once we get a slide, this is how a neuroendocrine tumor looks like. How do I go back?
Dr. Dhall, can you maybe talk a little bit about interpreting what we're looking at?
Sure, yeah.
I personally
So,
don't know what that means.
Different type of, there are thousands of tumors, and neuroendocrine tumor looks like this. It's very easy to train your eyes. It's one kind of tumor. You can diagnose it very quickly the moment you see a slide. These are all tumor cells. They are small. They are very uniform. They are monotonous, and they are arranged in either solid nest or trabeculae, like that. So this is a very classic appearance of neuroendocrine tumor. Once we see something like this on the slide, we have some immunostains we do to make a diagnosis, synaptophysin and chromogranin. And then we look at mitotic figures. This is like a low-grade tumor. I don't have a picture of high power to show you mitoses, but on the rightmost picture, that's a Ki67 immunostain slide. Thank you. So this is Ki67. See these brown dots? These are the proliferating nuclei. So we stain one slide with Ki67 immunostain, then we see how many brown nuclei are there, and see there are very few brown nuclei. That means this is a low-grade nuclei, very low proliferating tumor. And if you see the other tumor, there's another tumor. If you see the H&E, it kind of looks similar, right? Those same cells with uniform cells. But look at the Ki67 slide here. There are a lot of brown dots there. So, and the question is about the number, right? What number it is. So if you see, the tumor is very heterogeneous, So if, depending on where you look, like in this area, let's talk about in a biopsy. Let's say we have a biopsy and we get this much amount of tissue, we'll capture only these nuclei. If this is a resection specimen, we can capture this area where there is more cells with brown staining. So it really depends where the biopsy is coming from, and if there's lots of tumor, and your biopsy may not capture the most proliferative area of the tumor. But when we get a resection specimen, we examine it, we make a lot of slides, and then in every slide we will look for mitotic figure. Like here, I don't see any mitotic figure, but then we decide based on mitotic figures which slide we need to stain for Ki67 index, and this is what you see. And then so we pick the area which is most staining, and then we count the number of nuclei which is not staining, and we give you a percentage. So you can see how variable it can be depending on which slide you stain. It is subjected to inter-observer variability, and then how we count it. Long time back, we used to do visual estimation, like you look at this slide, it's roughly, everybody can make a guesswork here, right? How much percentage is brown cells? I would say in area, this area 0%, no staining, but here maybe 10% of the tumor cells staining. That's called eyeballing and visual estimation. But now there's a lot of recent literature which says that visual estimation is not good enough. Your eyes are not good enough in saying what is the index. So there are multiple ways of doing it. Some institutions, they take a picture and they will count every cell. Now per WHO, you're supposed to count 500 cells and sometimes 2,000 cells. And it's not easy to count 2,000 cells. And seriously, nobody does it. It's in the literature. What we do at Cedars, we have a computer system, and the computer system is trained to pick these brown cells. So what we look at the slide, we figure out whichever area is picking the most brown cells, we put circles around it, and we feed the slide in the computer, and the computer will measure all the brown cells versus non-brown cells and give you a number. But number may vary. It may be 1% in some areas, it may be 10% in other areas, but we go for the hotspots, we call hotspots. Wherever the highest density areas is, we give you the number from there, because that's going to decide how bad the tumor is going to be. So this is all about grading. And let me show you another slide.
Can I ask you a question?
Yeah.
Which of these is the key 67 and which of these is my high power field of the four? Or are they're all different, right?
They're all different. The pictures are taken at different high power fields. So in the microscope, we have a lot of objective lens.
Okay.
So it depends, like, if you see, this is a low power. This may be a 4x view, and that must be 20x. And this is also 10x, but when we look at the Ki-67, we go to high power, which is 40x magnification.
Okay.
Yeah, so right now you won't see the magnification here, but yes, we all count the index in high power, which is 40x, yeah.
So is that the same picture? That's the same picture but magnified different?
Yeah, these are different magnification, these are pictures, yeah, yeah. So just showing you the density, and this is a high-grade tumor. Again, if you look in the low power, which is an H&E appearance, the cells look similar, right? The G1, G2, G3s, they look similar. All the neuroendocrine tumors, they have uniform cells, they have abundant cytoplasm, but it's just the proliferating cells. Look at the amount of brown cells here. There are too many here. This is more than 20%. So that's a high-grade tumor. So again, the grading is very important, low grade versus intermediate grade versus high grade. And this is the grading, what I showed you on the first slide based on mitotic count and Ki-67 applies to gastroenteropancreatic neuroendocrine tumors. So neuroendocrine tumors in the stomach, small bowel, large bowel, pancreas are all graded similarly. But the lung grading, the tumors in the lung, they are graded separately. So see, all the classification in gastroenteropancreatic neuroendocrine tumors are developed by gastrointestinal pathologists, while the lung neuroendocrine tumors is developed by lung pathologists. So in lung tumors, the Ki-67 is not that important in grading. It's the mitotic count that decides the grading of the tumor. So again, the grading is site-specific.
What is the importance, I know this sounds probably very basic to you, what is the importance of grading the tumor?
So the grading tells you how proliferative the tumor is, how fast the tumor cells are growing.
So
And
low proliferation is lower.
It's lower proliferating tumor, means lower, it divides slowly. So it's a very, you all have heard carcinoid tumors are very slow growing indolent tumors. If you consider small cell carcinoma, which is a neuroendocrine neoplasm, it's commonly seen in lung in smokers, and that's a very high grade tumor. So that means there will be like 80% or 90% of tumor cells are proliferating. So the tumor cells proliferate very fast. More they proliferate, more they metastasize, more they have distant metastasis. So low grade, yeah, it's not good to have a tumor, but it's better to have a low grade tumor than a high grade tumor. Yeah.
I never knew, I always read it, and I never knew what
Yeah.
the difference it was.
Grading is critical. You must have heard of benign tumors versus malignant tumors. And benign tumors are lipomas, like fat tumor. We all may have some kind of benign tumors, which is okay. You leave the tumor, it won't grow, and it will stay there for 10 years. Malignant tumors is colonic adenocarcinomas, colon cancers, pancreatic cancers. Those are bad tumors, with very low survival. but neuroendocrine tumors lie somewhere in between. When it was discovered, it was used to be called benign, and in an older classification, some of the neuroendocrine tumors were considered benign tumors because they were very small. But you study them more now, they're not considered benign tumors. They're all potentially malignant tumors because they all have capacity to metastasize, to go into the lungs or brain, but it depends on how fast they're proliferating. So a higher proliferating tumor or a higher grade tumor would proliferate more, would go and metastasize more often.
One doctor in Newbury Park still thought carcinoid was a fake cancer when I was cut last Sunday.
Yeah.
So he thought it was a fake cancer, and I educated him.
Yeah. So, yeah, and so it's even until recently, surgeons and clinicians used to call us, okay, carcinoid tumor is benign or malignant. I say, they're not benign, and you just grade them and you just stage them. So if you have a very small neuroendocrine tumor in the pancreas, less than 1 centimeter, no lymph node metastasis, very likely nothing would happen, and the surgeons just enucleate it, and then it's benign because it will never come back maybe in 10-20 years. But if you leave that tumor behind, and depending on the grade, it may cause metastasis. So yeah, it's all about the grading. First, the recognition that it's a neuroendocrine tumor. The low-grade tumor and an intermediate grade tumor, they are called well-differentiated. Now, that term is very important. Once you have a diagnosis of neuroendocrine neoplasm, look in the report, it's well-differentiated or poorly differentiated. Well-differentiated, all of well-differentiated tumors look like this. Here I see, that's a mitotic figure. That's how you identify mitotic figure. Cells undergo mitosis cell cycle, and these are the nucleus. See this nucleus? They are very bland nuclei, and then here the chromosomes, they separate here, and the cell is dividing. So initially we used to grade these tumors based on mitotic figures, how many mitotic figures are present. We still use mitotic figures. But Ki-67 proliferative index is very sensitive, and it picks more cells in mitoses than mitotic figures.
So with the breakdown on the Ki-67, you said it looked like it was less than 3%. There were 3 different categories.
Yes.
Grade 1, 2, and 3. How do the percentages break down in all of the cases you look at?
So as I said, most tumors will be low grade, depending on the site actually. Small intestinal carcinoid tumors, they are mostly low grade. But low grade tumor does not mean that it's low stage. So it needs to be very clear. Like patients may present with liver metastasis. The tumor may be everywhere, but if it's low grade, that means a very low proliferating tumors. So if you see all metastatic tumors and it's a neuroendocrine tumor, most will be low grade, But then what I see in practice, if fair number of intermediate grade, but high grade, fortunately they are rare tumors,
So I think for many patients, since they experience what another patient mentioned, that the doctors are missing this and they're being misdiagnosed, by the time they do have a biopsy, it's a liver biopsy, because at that point they found liver metastases. Is there a difference in what you see in that sample, different from, let's say it was a primary small bowel?
Okay, so I know it says doctors do not diagnose them, but these tumors are very indolent. They are very small, and no matter what imaging you undergo, the smaller tumors you can't see, and so nobody knows until they grow and they become liver metastasis. So they look different? Yes, they will look similar in primary site and metastatic site, but grade may vary. I don't have the exact numbers, but I would think maybe 80% of the times the primary tumor and the metastatic tumor would have similar grade, and even if have different grade, it would be not a huge difference. So if you look at the numbers, if you have one, first of all, making a determination of 1% versus 3%, it's very difficult, and I don't think clinically it is that important. Yes, we had to make a classification. People like numbers, but 1% and 3% is not different. So if you see that difference, yes, that you will find within the primary tumor, different sites, and within primary tumor and metastasis. But a huge difference is very rare. For instance, if you have a low grade tumor in the primary in the small bowel and a metastatic tumor with 40% Ki-67, it's almost unheard of. We can see case reports, and there's one paper which is going to come out which will show high grade transformation, but those are rare. Most of the times it's a similar tumor and the grade is a little bit different in grading, and sometimes primary tumor may show a higher grade than metastatic tumor. It's just where you capture it. Yeah, so it's similar, but it may be a little bit different. So in a primary tumor, grade may be G1, in metastatic tumor the grade may be G2, or vice versa.
And following on that, there was a question submitted. Said, is it common to get a range on Ki-67 rather than a fixed number? And does the Ki-67 remain the same over time?
No. So yes, we do see a range in the tumor. Every tumor will show a range, as I showed you, from less than, some areas will have no staining, some areas will have 2% staining, but it's the hot spot. It's the area where there's most proliferative activity which will decide the fate of the tumor. So it's better to give one number than give the range. But we sometimes say in our reports the tumor that it's variable, ranging from 1% to 4%, but the 4% will decide the fate of the tumor, and that's the number we give in the reports. So yes, there's a range, there's always a range, but we give the most, the value in the hot spot. And what was your second question?
Does the Ki-67 change over time?
It does. It does, but not very much. So if some tumor, if we see biopsies from one patient at different time intervals, it may be same, or in some patients it may change over time. In some rare patients may undergo high grade transformation. So yeah, it's everywhere. Most cases I think it doesn't change a whole lot, but I have seen high grade transformations in neuroendocrine tumors.
And then can you talk a little bit about the receptors and the subtypes? We hear about some of the medications like lanreotide or sandostatin and how that binds to receptors.
Yeah, so in pathology, I've heard about somatostatin receptors, and this is coming more from Europe and Japan. In United States, I don't think in practice people are doing somatostatin receptors on tumor cells. We don't have that antibody in our lab, and in fact most labs will not have that antibody. It will be only in reference laboratories, and I'll tell you why we are not using them. Because every patient undergoes Octreotide Scan to see how far the disease has spread, and that Octreotide Scan is based on the somatostatin receptor positivity. So it's like an ancillary test. It's something like if there's a neuroendocrine tumor, you do serum markers to find out if the tumor is functioning versus non-functioning. Some patients may have insulinoma, gastrinoma. We have immunohistochemical stains for that, but we don't do it in pathology. It's very important to be cost effective. You all have seen the bills. Every antibody costs some money, and there's no point in doing, at least right now in the practice, to do these receptor stains when there's Octreotide Scan already. I believe if there's Octreotide Scan positive, it's usually patients are receptive to the somatostatin analogs. So we are not doing it at least in clinical practice, these receptors in the tumors, because most neuroendocrine tumors, they have somatostatin receptors in them.
So can you explain the process? Someone asked what a frozen section was.
Oh.
And I thought maybe you could describe the whole procedure. So as
Sure.
someone gets a biopsy, and what then happens? Does it go immediately to
Yeah.
you?
It's very exciting as a pathologist. I think I'm doing surgical pathology because of frozen sections. It's what happens when the surgeon is operating and when the tumor is out or when they take a biopsy. Must be talking just like a pathologist. Tumor, where patient is less is tumor. Yeah, every tumor is a patient for us. So they give us a call and we go there and take the tissue from them, or there's a courier. So we have a frozen section room in our pathology department. You are more than welcome to visit if they allow. So we get tissue. So we get tissues in few minutes. It's very quick. In less than 5 to 10 minutes, we get the tissue. We look at the tissue. Depending if it's a biopsy, we freeze the tissue. So we have a machine and we have a media. We put the tissue in the machine and it snap freezes the tissue. And once the tissue is frozen, it's easy to make a slide, to put the tissue on the glass slide and stain the glass slide. And then we look at the tissue in the microscope. And then we can give a diagnosis to the surgeon in less than 20 minutes, usually in 10-15 minutes, what the tumor is. So sometimes, for instance, for neuroendocrine tumors, the tumors are so small, and when the surgeon goes there and they don't know whether there's neuroendocrine tumor or not, or they want to be sure they have removed the tumor. So they'll give us a specimen, we'll open the specimen right in front of them, we'll show them there's tumor, and then they want to know, most importantly, if the tumor is removed, how far the margins are from. You'll see you'll see in the path report, resection margins. That's very important. That tells us whether the tumor is completely removed or not. So that's how we do in frozen section. Cases like enucleation, when they remove the tumors from the pancreas, since it's otherwise a major surgery called Whipple resection, sometimes they just remove the tumor and they give it to us, and we quickly make cuts and make a look on the microscope, decide what tissue we need to freeze. That all takes experience, many years to learn that quickly decide which area I want to see in the microscope. Then you freeze the tissue, prepare the slide, and look at the tissue in the microscope, and then tell the surgeon whether he's close, whether he just resected it, or he's very far from the tumor, or he has transected the tumor. In that case, he will go back and take more tissue out. Dr. Nissen, he gives us a lot of neuroendocrine tumors, and he always asks for frozen section. And more, they ask for frozen section because we need tissue fresh to be frozen for any future research. Some of you allow for tumor banking. We bank the tumor, so in case in the future if some new test comes up or for research purposes, we can freeze the tissue. Because the moment you take the tumor out, it doesn't receive its blood circulation and the tumor cells start dying. So it's better to examine the tissue as fast as you can, or put that in formalin. Formalin is a preservative. It just keeps the nuclei in the same state. And once the tissue is in formalin, that's the other way. Once you do either a frozen section or put the tissue in formalin, and then you examine the tissue. That's a very extensive thing we do in the pathology department, and we put the tissue in the paraffin block, and the tissue in the paraffin block can stay for many years. So if somebody asks me, can I do the Ki-67 in a tumor resected in 1990s? Sure, we can retrieve the paraffin block and do the stain. So we have tissue in the paraffin block, and then frozen section is for basically a quick diagnosis for the surgeon, so they can do the proper surgery. Sometimes they don't have a diagnosis. For instance, if there's a neuroendocrine, say there's a tumor in the pancreas and they don't have a diagnosis, and it's not very uncommon not to have diagnosis and go for surgery. So they'll remove the tumor, they'll ask us for a frozen section. If it's a neuroendocrine tumor, the surgery is different, and if it's a cancer, the surgery is different. So diagnosis matters, the status of the resection margin matters. So it's difficult, it's challenging, and then sometimes it needs a team effort. You talk to the surgeon. It's all what you see with your eyes.
How long have those paraffin blocks kept?
I think, I'm not sure, I think maybe 10 years to 20 years. I think Cedars keep it for 20 years, but you're required to have it for 10 years. Not sure.
is there an infinite amount of the paraffin blocks? I mean, how
Yeah.
much do they have of it, and how many times can they research to see what medicine to give me?
Sorry about that. Yeah, it again depends on various practices. You know, we think we are really good in what we do. So it depends. Most pathology department, let's say if it's a 10 centimeter tumor, we take minimum 10 sections of the tumor. So, and the rest of the tumor, you examine it very nicely, but then ultimately it's discarded because you can't put the entire tissue in paraffin block. And so again, that's what gross examination is, gross pathology is, that we look, we find where we think is the most informative area of the tumor, and we take small sections and then we put those sections in the paraffin blocks. So yeah, it really,
For how long? I mean, that was answered.
yeah,
Was in my
we
mind.
can keep it for as long as you want.
And where? I mean, is there a site with?
Oh.
Must be forever. I mean, your guys must have a really.
Yeah, I think we archive our tumor blocks, and it becomes so many. You know, if you come to the pathology department, there's one wall with blocks and blocks and slides. In fact, in my own office, I've done so much research. It's all blocks of neuroendocrine tumors. Yeah, yeah. When Dr. Wolin was here, we had a lot of neuroendocrine patients here. We had a lot of neuroendocrine tumors, so we did some research. Yeah.
How objective is the Ki-67 grading? Because, like, if I had it done here as opposed to Vanderbilt or somewhere else, would the numbers agree, or is it?
No, there will be some disagreement. I think what is more important, there shouldn't be a disagreement between 2% versus 20%, because that's a huge difference. But to me, a difference between 1 to 2%, 2% to 4%, it's okay, because you know, it's just which area you want. And then first which area you pick to do the stain. The second is what technique you apply to count them. Some people will do manual counting, some people will do by computer assisted image analysis, and even if you take two computer assisted image analysis methods, they will have they can have different numbers. And recently there was another study, the paper, it's not published yet, but I reviewed the paper, that they studied one particular Ki-67 slide, and they ran by 3 different machines, because every center has a different machine, different calibration, and there were different numbers from different labs. But more importantly, every number correlated with survival overall. So there may be some variation, there should not be a huge variation. And only in recent years, if you look, there's a lot of literature on Ki-67, how to do it, and best method to do it. It's still more and more papers are coming, so it's very variable.
So it's getting better.
It's getting better. It's getting better, but and there are new antibodies coming, and even, you might think the computer-assisted image analysis is the best, right? But it's still not the best, because you have to. What we do the visual estimation. I count roughly, good numbers, and I have a number in my mind, and I let the computer do it. And sometimes the number in my mind is not what the computer gives. Then I have to look at again, because computer might count a non-neoplastic cell which is staining with Ki-67. So for instance, there are tumor cells, and there are a lot of non-tumor cells in between, lymphocytes in between, which might stain with Ki-67. So computer is trained to recognize what are tumor cells, but it may not. If the non-tumor cell is the same size, they go by the size criteria. So even the computer may be wrong. So it's just, again, it should be all put together, visual estimation plus manual counting and computer assisted image analysis.
Do you ever do any analysis on bone metastases?
Okay. So yes, we do Ki-67 index in the primary tumors and metastatic tumors, even in the bone metastases. But you have to remember what kind of tissue we get in the pathology department. If you have an FNA, what is called fine needle aspirate, sometimes they just suck tumor cells from the needle, so their tumor cells are very scattered, and the biopsies are very difficult to obtain sometimes, so the tumor cells are very few, and the fewer tumor cells you have, a smaller sample, the Ki-67-8 index may not be accurate. So there was one paper, they took a tumor and they took 5 different samples of tumor from different areas. Ki-67 index was different in different areas, but then they found out even one single biopsy, it's finally okay to decide the treatment, because it's not going to be huge, except for rare cases. Rare tumors are always there, which will suddenly have high-grade transformation. So if any one of you have noticed the different numbers of Ki-67, I think it's okay as far as not changing the grade. And we have to know it's not just one number, it's a spectrum. And it really depends what area you are studying, what antibody. The antibodies are different, the techniques is different. Yeah, so a lot of things are into play here.
Yeah, I've got a question on pathology. As they show size, grade, and stage, and they also did the Ki-67, but as an example, if you could help on the size of a PT2A NOMO, what that?
Okay, so that's the staging. Every tumor, every carcinoma or every malignant tumor is staged per AJCC Cancer Staging Manual. There's a cancer staging manual which will give us the TNM staging, we say. P is for pathologic staging. There's a pathologic staging which is done by pathologists on the specimen. Then there's a clinical staging and radiologic staging separately. So once we have the specimen, we will do pathologic staging, which is P. T is for tumor. So it will tell you the tumor size. So depending on the site, the T1, T2, T3 varies. And also on the depth of invasion sometimes. N is lymph node metastasis, and M is distant metastasis. Yeah, so that the one line will tell you everything. T2, N0, M1. N0 means no lymph node metastasis. M1 means distant metastasis.
And the second part of that, of the 3, the grade, a T1B. Could you explain what that grade, how you grade?
So that's the TNM staging system. The grade would be G1, G2, G3, or well differentiated versus poorly differentiated. Grade is not incorporated in TNM staging. Staging tells you the extent of the disease. The grading tells you the proliferation of the disease. And not every tumors we do Ki-67. It's neuroendocrine tumors. The grade is dependent on proliferative activity. So in that TNM numbers, you will not see the grade. It's just the stage.
And so the stage 1B is part of that T1B.
Yeah.
Even though they separated.
So if you go back before 2010, if you look at the WHO classification from 2000, the staging system was incorporating both grade and stage. But in 2010, they separated grade and stage. So TNM is just the stage, and grade would be well differentiated versus poorly differentiated, and then G1, G2, G3. If this is gastroenteropancreatic. If it's lung, it's similar. It's also decided by mitotic count, but it's typical carcinoid, atypical carcinoid. Typical carcinoid is like G1 tumors, atypical carcinoid is like G2 tumors. And then it's small cell carcinoma, which is very high grade tumor.
So is that typical versus atypical only for lung?
It's so, yeah. I mean, if you read older literature, the typical atypical is also used for stomach and pancreas, but these days we talk about low grade and intermediate grade. So if an old pathology report might say atypical, that is equivalent to intermediate grade. Yeah. But the cutoff for mitotic count is the same from typical to atypical versus low grade to intermediate grade. It's more than 2 mitotic figures. per 10 high power fields.
Or like, it says less than 5, so that means it's somewhere less.
What was that, Ki-67
That was
or
the
mitotic figures?
high
This is,
power
so when the cells divide, so how the tumor proliferates, one cell becomes into 2, 2 into 3, so they undergo mitosis. So a dividing cell we can identify by eyes by looking at the mitotic activity.
Thank you.
There's a question over here.
Just my question was blood work and indicators in the blood. The PH2A, the serotonin, I think chromogram or whatever that other one is. I'm a little newer at this, but does that run parallel with what you're talking about in
Yes.
pathology? Do they track?
So pathology, okay, in pathology it's a huge thing, you know. I do surgical pathology. I deal with tissue specimens and talking about this. But what you are talking is blood markers, which is done in the chemistry lab. It's done by machines. Surgical pathology is done by doctors, you know, looking at the slide in the microscope. The machines would measure serotonin level,
Yeah.
chromogranin level, and all
So
that.
there's no parallels with the grade of tumor, the growth of the tumor?
It does have, because chromogranin levels, if there is high serum chromogranin levels, it does tell us about the tumor burden. And once the tumor is removed, the serum chromogranins are done in regular intervals.
Mhm.
And if it's rising, that means the tumor is coming up.
Mhm.
Yeah.
If it's going down, just the opposite.
Yeah, it's opposite. For instance, yeah, it's going down, it's a good sign. Yeah.
Okay. Thank you.
But it's going down in the blood serum test, not because the Ki-67 is changing, but because probably the tumor load has gone down?
You know, both ways. I have read that if the tumor burden goes down, yes, the serum chromogranin will go down. But I've also read, and I've also seen in my own research, when the patient treated with somatostatin analog, the proliferative index goes down. So it's both ways. The tumor burden is going down, the proliferation rate is also going down.
How many people are in the lab with you? How many pathologists are there looking at neuroendocrine tumors?
So I don't know the exact numbers. We have 30 pathologists, maybe surgical pathologists. Most the neuroendocrine tumors are very common in gastrointestinal tract. We have teams like a gastrointestinal team, pulmonary team. In each team there may be 5-6 pathologists. And the neuroendocrine expert is, I'm considered to be a neuroendocrine expert because of my training, of my interest. So whenever there's neuroendocrine tumor, people usually, we say curbside consult. So if one pathologist has a slide, we'll walk to the pathologist's other office and show the slide and talk about it. And then we also have daily conferences where we show cases, slides to each other. If there are any potential difficulties, we solve them by discussion.
So we'll want to know when you're taking your vacation and schedule our surgery.
Yeah.
That's right.
We can get images online. You know, we're supposed to have email.
In Hawaii, right?
My phone always rings to my cell phone, so yeah. So surgeons call me sometimes in the evening, in the weekends. I do pick up my phone, yeah, we do. Frozen sections are always done in the weekends, at night times. But most of these are elective surgeries, you know. Yeah, neuroendocrine tumors are usually elective surgeries.
When you spoke about keeping the tissue in a bank, once they were received here, are they then put in your bank here?
No, if you bring original slides from UCLA, the slides will go back to UCLA. But it depends. If you order unstained slides, so we make a paraffin block, right? And then from paraffin block, we make one H&E slide usually. And then we store the paraffin block and we store the H&E slides. But if a second hospital is requesting the slides, like for our Cedars policy, if somebody is requesting the slides, we cut additional slides from the paraffin block and we send those slides. You don't need those recut, we say recuts. We don't need to get those slides back. But if we send the original slides, For instance, fine needle aspirations, they're original slides. They are, they aspirate the cells, they put it on a slide. You can't make another slide of it. So anything original which is sent out usually comes back to the original institution. But if we order slides, if you got unstained slides here, it must be with us. I always tell the surgeons and the clinicians, people think pathology is, I don't know how to describe it. It's very objective, or it's like pathology is final. We have different opinions. And, most of us are all trained pathologists. They undergo residency training, but there are some places where neuroendocrine tumors are rare tumors and they may be misdiagnosed. And I always tell the team here, whenever you're treating a patient here, it's very important to get the pathology slides and get it read here. Some clinicians object to it because, it's all about the cost. It takes cost into play, but I think it is very important for the right diagnosis. So we really, at least at Memorial Sloan, when I was a fellow, every patient who was getting treated over there, their pathology was being reviewed by pathology. At Cedars, it's still not consistent. And one thing I really liked about Dr. Wolin is that he always used to get pathology material from any institution and get it reviewed by us. And he was really involved in the pathology. So yeah, it's very important to understand the pathology because that decides everything. And yes, there is sometimes a misdiagnosis, sometimes a change in the grading, and it all depends on how much expertise you have. Most of the times they're accurate. I will not, they are all our colleagues, but it's nice to see the patient's pathology while treating. Yeah, I don't know the exact number. It's maybe less than 5%, less than 2%, but still, it's just individual patient we worry about.
I think we have time for maybe one or two other questions.
How many times does a patient usually go through the pathology process? I know it's initially a diagnosis and then during resection or debulking. Is there a third time after treatment that you get a pathology?
Yeah, so we come into picture whenever we get a tissue. So first time initial diagnosis is obviously very important. In neuroendocrine tumors, patients have a long course. They may develop metastatic disease later on. So it is advisable once they develop metastasis, they give us more tissue. So anytime the biopsy is taken or there's a surgical procedure done, then we come into play. Otherwise, once the diagnosis is written, it's the final word. It's a medical legal document, so yeah.
I don't know if this is your area, but circulating tumor cells, do you know anything about whether detection techniques are getting better because that's how they're metastasizing?
Exactly, that's the future. I have heard about it. And we are writing a paper on this colorectal carcinoma molecular biomarkers. And the last paragraph we wrote about circulating tumor cells. I know very little of it, but I know there's intense research going on. And I think the important thing is we don't know which tumor, which part of the tumor is most important. It seems the circular tumor cells which go in the bloodstream, that goes to the metastatic site. So those tumor cells are the main tumor cells to focus on, right? So let's say we could do Ki-67 index in the circulating tumor cells, that would be so great because the primary tumor is already removed. It's not in your body. It's a circulating tumor cells, and the genetic makeup of those cells are different. So once we are into that technology, that would be really nice to do every test on it. It does appear different. Neuroendocrine tumors appear different. Neuroendocrine tumors are very well circumscribed. They are circumscribed means they look well circumscribed. They're not ill-defined. Pancreatic cancers, they're very ill-defined. It's very hard to tell them where is the cancer. Everything looks very hard. It's very, yeah. But again, this is what is called gross pathology. For instance, small intestinal carcinoid tumors, it's a very classic look of it. And I can show you one or two pictures. It's, you can just look at them and identify that's a neuroendocrine tumor. The small bowel carcinoid tumors are actually very interesting. The primary tumor tends to be really small, and the lymph node metastasis tends to be big, and then it's biologically very interesting. And such a small primary tumor can cause, extensive liver metastasis. This is a small intestine here, and that's the mesentery. That's a lymph node with a tumor in it. And see, you can't even see a primary tumor. That's a primary tumor. So, and then I have a picture here on the left. I can't see it. Oh no, 1 minute. And so we make cuts to the tumor, and if you cut this tumor here, that's a tumor here. So that's how these tumors are missed, because even if you scope them, you see the mucosal surface only. You don't see the cut part of it. So that's a very classic look of a small bowel carcinoid tumor.
How do you determine that that's the primary tumor? What's the determination?
Because the tumor is right here. It's in the primary site. That's a very interesting question, actually.
Yeah, but how do you know it's the primary? It doesn't say primary.
So most primary tumors tend to occur from the mucosal surface. They tend to arise from there. So for instance, we know carcinoid tumors, they arise from neuroendocrine tumor cells, which are present just beneath the mucosal surface. A metastatic tumor would actually present more on the serosal aspect, So tumors arises from the mucosal surface. For instance, colon cancer, you'll see a huge mass in the colonic mucosa. That looks like that's a presentation of a primary tumor. While if you see on the outside, it's a presentation of metastatic tumor. So it's all the patterns which tells us. Like if there's one mass in the liver, and there's no other masses, you assume this is a primary tumor in the liver. If there are multiple masses in the liver, you think it's metastasis. But you're absolutely right. Any given tumor can be a metastatic tumor. So for instance, if you have a tumor in your, this is rare scenarios. So by just the configuration of the tumor and by just the look histologically, we can tell it's primary versus metastatic. And there's immunohistochemical stains, but a metastatic tumor can mimic a primary tumor. So, yeah.
Years ago, I asked a doctor, how do you determine the difference? And he said the primary is generally in the lining of the organ, whereas the metastasis is in the organ.
That's what I'm saying. So this is the lining. This is the mucosal surface. The food, this is an open, if you look at the small bowel, this is open. We have opened it with the scissors. So this is the food passes through here. So this is the lining. These are what we call mucosal surface. And this is outside. So if there's a tumor here, it's not in the lining. So this is metastatic. This is in the lymph node. And this is the lining here, and the tumor is right here. So this is primary. But a metastatic tumor can occur in the lining. Yeah. It's it's not easy.
Well, I want to thank you so much.
You're welcome.
For
Yeah.